why are extraintestinal manifestations important? So about half of our patients with IBD will have extraintestinal manifestation at some point during their lifetime. And importantly, about 30% of them might have this onset even prior to the diagnosis of IBD. And the kicker is that primary treatment for IBD may be ineffective in many of these situations. So let's get into the one that is most commonly present, which is IBD-associated spondyloarthritis. I'll be calling it SPA for convenience purposes. So it comes in four major flavors, I would say. So there's axial SPA, then peripheral SPA, which includes type 1, which is acute, involves lesser number of joints, most commonly in knees and often precedes the onset of the IBD and can also parallel the disease course. However, these things are becoming less important as we are discovering more and more about these extraintestinal manifestations. And type 2, this is a more chronic type, polyarticular. We think that patients who've had type 1 over a period of time, if they're left untreated, develop more erosive damage and go into type 2 peripheral SPA. And then there's something called enthesitis, which is the inflammation at the insertion of the tendon onto the bone. So two of the more common ones that we know about are Achilles tendonitis, plantar fasciitis, very commonly seen in our primary care practices. And finally, we have dactylitis. You might have heard this from psoriatic arthritis. This is sausage fingers or inflammation of the entire digit itself. So when do we suspect axial SPA? There are some questions that you should be asking in most patients. Do they have chronic lower back pain or neck pain? Does it wake them up from sleep? Is there morning stiffness associated? If the answer to any of these questions is yes, you should probably send them for x-rays or MR spines, check HLA-B27. The HLA-B27 more for us to know whether this might have a worse prognosis than HLA-B27 negative arthritis, and of course refer to a rheumatologist. The X-ray and the MRI pictures that you see on the right gives you an indication of what these might look like on imaging. So the MRI shows hyper intense flare at the joints, and the one on the bottom right corner, which is the X-ray, shows the fusion of the joints where there has been long-term damage. Peripheral SPA, these usually are typified by swollen, red, hot or tender joints. These are mostly non-erosive, and clinical diagnosis most of the time do not need imaging. Although I will say more recently I have seen rheumatologists ask for ultrasounds of the joint to look for fluid collections in the synovium. So maybe these things will change over a period of time. Coming to treatment, now this is where I want everyone to focus on. So let's look at what are the different options which are available and what can be used in the different circumstances. So the conventional DMARDs like methotrexate, sulfasalazine, azathioprine will work in pretty much all circumstances except for axial spondyloarthritis. TNF inhibitors are probably the ones which have the greatest evidence for all types of SPA. IL-12/23, ustekinumab, risankizumab, mirikizumab in their trials in psoriatic arthritis have not shown to have any benefit for axial arthritis, but they do seem to benefit the peripheral arthritis, except for Tremfya or guselkumab, which does seem to have some benefit in axial SPA. And the other medication which works for pretty much all types of arthritis are the JAK inhibitor. So both UPA and TOFA are very good options in these situations. And just to remember, the dosage that we use for SPA for both JAK inhibitors are actually much smaller than what we use for Crohn's and ulcerative colitis. And then IL-17 inhibitors like secukinumab are not recommended because they do portend a worsening outcome and can sometimes unmask IBD in some of these people. Now coming to skin manifestations, I'll quickly go through some of the common ones. So pyoderma gangrenosum or PG can be seen around the legs or around stoma. Thing that everybody has to know about is we should not debride them. We should not cause any kind of mechanical trauma because they tend to worsen. This is also known as pathogen. Does not really track with IBD activity at all. And when it comes to treatment options, high-dose steroids, tacrose, cyclosporin, TNF inhibitors, topical tacro, all of these can be used. As a sidebar, I would say that TNF inhibitor, infliximab, is the one medication which has actually been shown in a study to be beneficial for pyoderma gangrenosum. This has actually been studied. Erythema nodosum, this is something that tracks with disease activity. These are painful red nodules which will be seen on extensor surfaces, usually on the leg more commonly. Parallels IBD activity, as I said, and treating the underlying IBD does tend to treat the EN also. Metastatic Crohn's, I had never seen this before I came to Mount Sinai, but these can be seen in any part of your body on the skin, and you'll see granuloma on histology, can be really bad on the genitalia, runs independent of the IBD activity, and again, underlying treatment for the disease will tends to work for metastatic. I will say people who have metastatic Crohn's can be very, very hard to treat and can be quite recalcitrant to treatment. And then some of the other oral lesions that we see are aphthous stomatitis. The word explains itself. You'll see aphthous ulcers inside the mouth. Periodontitis, which is loosening of the gum, the inflammation of the gum itself. Very commonly seen in actually perianal disease and does tend to track with IBD activity. And finally, the ocular manifestations. So there are three main flavors: episcleritis, scleritis, and uveitis. Just depends on which part of the eyeball is involved. The most common one is episcleritis. It's probably the least dangerous one of all three. Honestly, I don't know how to differentiate between any of them, so I always send them to an ophthalmologist. But for our purposes, I would say episcleritis is something that does tend to track with disease activity. The rest is a kind of unpredictable. Some studies which show they do, some others say that they don't. Common things to note for episcleritis: there is redness with burning and pain. Scleritis, it's much more red is all I can say, much more diffuse, much more severe in its pain, and can also lead to permanent damage. That's why we need to refer them to the ophthalmologist. And uveitis, you can get the pain, blurry eye with photophobia. Again, it's hard for me to differentiate. I always have to send these people to my ophthalmology colleague, and I would not second guess myself on any of these situations. So some of the take-home points. Most importantly, please assess the IBD activity. EIMs do tend to track many of them, and treating the underlying disease by disease assessment might be a good way for you to figure out if just optimizing the treatment might help cure the EIM. Ask certain important questions. Ask about morning stiffness, swelling, hot joints, redness of joints. These can help triage if these patients need more escalation of therapy or a different type of therapy. Palpate the joints if you can. You will find many a times, it's hard, but I will tell you, you can find fluctuance of the joints. If you put the joints right next to each other, many a times you'll be able to see the swelling, which is different from one to the other. And then things to remember for axial SPA, anti-TNFs, and JAK inhibitors. I didn't mention here, but NSAIDs are also quite effective.